We're going to talk about a couple things today, one of which is going to be substance use disorder, pain and substance use disorder, because it's what I do. So first of all, I run right now probably one of the only pain and addiction programs in the country. And I'm very, very grateful. We are a Center for Excellence for the state of New Jersey, so I'm able to give quite a bit of guidance to the medical board, to the governor's office. I work with the Department of Justice, and we're recipient now of several federal grants, SAMHSA grants, and I'll talk a little bit about some of the work we're doing and even some of the work we did earlier today in the community prior to this. So we'll go ahead and get started. So why am I here? The number one health crisis in our country, second to COVID, and will be number one again, is the U.S. Opioid overdose deaths. They're dramatically increasing, and they got a lot worse during COVID. From 2001 to 2016, there was almost a 300% increase in death rates. And again, as I've mentioned before, as we look at that data going up, it's going up and up and up. I will tell you that maybe, just maybe, we're plateauing a little bit, but I'll have that data for you guys a little bit. I get the data pretty much right from the governor's office as it happens. And we know that we still have this aggressive opiate prescribing, which we'll talk a little bit about in the future. So should we start taking a reevaluation kind of how we treat opiate management? And the reason I started doing addiction medicine was because of the opiate overdoses that we started having. But I did, and I still do, over 25, now 26 years of pain management. And what did I do when we found someone who was a substance abuser, right, in pain management? We did what we were taught to do, kick them to the curb. That's what we did. We were taught, I did lectures of this, kick them to the curb. And what happened when you kicked our patients to the curb? They overdosed, because it was a sure way to get into heroin and now fentanyl, and obviously that led to really bad stuff. And that's why we started doing what we're doing and started talking about proper prescribing, which a lot of you have been listening to me over the years, and now I'm going to talk to you a lot about why we should all be doing addiction medicine also, especially primary care. So we kind of look back at a timeline. We knew in the 1960s and 70s, cancer pain was how we saw our studies, right? We thought opiates were pretty much end of life, right? And that wasn't 100% great either, right? Because we know people suffer from chronic diseases that do require opioids. So by the 1986, chronic use of opioid therapists in non-malignant pain saying, hey, use them now for not, but it looked at only 38 cases in the literature, so there wasn't a whole robust amount of data out there. And by 1995, Purdue kind of started out with their campaigns, which we all now know is history, right? And we talked about pain as the fifth vital sign. Some of you guys, and I know you, have even sat on the board, right? And hospital boards where you said, wow, our Gainey scores are bad. You're not treating people in pain, so you can't keep your credentialing with us, right? We all know that happened, right? So people then said, fine, I can't fight the system, and what did we say? There's no ceiling doses, there's no adverse events, and you don't get addicted to OxyContin, right? We said that. And then what happened was campaigns went out. You're just afraid to do it. You have opiophobia, right? And they actually gave that as a name, which is pretty interesting. And then FINE said that there's all these great benefits of opiates, not just for pain, right? And I think some of you have heard that. But if you look at this, the opiate epidemic numbers went up and up and up. Right? We're at war. Right? I'm wearing my pin today in solidarity. We're at war. And I always like looking at data that is kind of meaningful in a different way, right? And if we look at the opiate overdose and compare them to people that we've lost in war, it's more, right? And I'll tell you, this data is actually a little bit old. This goes back from 2014. So this is it's much more so as we look at it now. All right, so what are we dying on, right? What is it? right? So at that 2010 to 2015, and I'll show a little bit later, we were writing a lot of opioids, right? And that was sort of the time frame where people were like, wow, they're getting more prescription drugs than heroin and fentanyl, right? But if you look at year by year, right, you'll see that what's killing people now are synthetic opioids, right? This is fentanyl, right, that we're coming out on the market, right? And unfortunately, we're cooking these in labs, right? And they are shipped in right into our airports and across the seas into our ports. And if you ask yourself, I'm going to show you a data a little bit, right? Like, why is New Jersey, like, why are we in the knee deep in this, right? Well, the reason is we've got great airports, we have the I-95 corridor, and we are surrounded by water. That's why. And if you look at the data, even disease vectors, I always like it, like some of you remember I started my career in doing HIV and HIV pain and all of that. If you looked at the I-95 corridor, you saw disease, right? The highest risk of getting HIV was along the I-95 corridor. It's access, it's mobility. That's what it is. And in New Jersey right now, absolutely everywhere. And I would challenge you, if you doubt me, go to any Wawa and sit in your car for 10 minutes longer than you think you should. I promise you, you'll have someone coming around you. It is absolutely everywhere. The access to drugs are easier now. We've done some studies, I think this is, I apologize guys. We've done some studies that demonstrate it's easier to get drugs right now than food. Food. Think about that. Food. All right, so if we look at, these are morphine equivalents, right? The darker it is, the more we're prescribing opioids. So you're seeing that on the top, and at the bottom, the darker you see it, we're increasing prescribing, right? So that's the vector that's increasing prescribing at the moment. All right, but if we look at age-adjusted rates of overdose deaths in the United States, look where we are, New Jersey, right? So the darker the blue, the higher death rates. So we are in the opioid crisis knee deep. So it is what it is. Now I know some of you are like, some of you might be from New York and you're like, look at us, we're not, well, smarty pants New York, you're not getting better. You're getting worse. But it's kind of what I was telling you, it's access, right? If you kind of look at the states that are the knee deep in this, it's access, it's rural poor, and our rural poor getting access into care and treatment, which is why I'm going to talk to you a lot today about how everybody should be considering doing addiction medicine in their practice. Okay, this is what I talked to you about before. The Dawn data 2011 changed the world, where it showed that for the first time ever, pharmaceutical use 33.9%, over 26.6 illicit drugs, right? So that was the year that people were like, wow, we have to do something. And by the way, that was the year we started doing addiction at the NMI. So I said, we're done. We're not kicking anyone else anymore. We got to own this. And that's what we did. And I think it was the best thing we ever did. I always throw this out, and I know there's going to be the marijuana question, so I'll get to that. So when we talk about who are at risk, so our alcohol users are 2 times greater risk for substance use disorder. Marijuana does present as a 3-time risk, but nothing compared to cocaine. And yes, cocaine is not an opioid, and no, it doesn't have to be, quote, detoxed, but it gives you a 15% greater chance of becoming a substance user. And then obviously opioid painkillers, 40% greater chance of becoming a opiate user. Okay, so what can we do, right? How many people here, by a show of hands, in medical school got any more than an hour lecture on opioids? Show of hands. Any more? In your pharmacology, did you get more than 1 hour? Right. Right? We didn't train doctors on this. I gave a lecture this week to the circuit courts of New Jersey, the judges of New Jersey. I gave a lecture similar to this. And then prior to that, to the family judges who asked me what to do about marijuana. I'll talk about that later. I'm like, you're asking me, you're making the laws. But when I said there that we didn't train doctors on opiate management other than a couple hours in medical school at best, they were shocked, right? I'm very proud to say our medical school, I've been doing this since I started, 25 years. We've been training our medical schools on, and we were the first in the country now to have both a pain and addiction program side by side in the country. So I'm pretty proud of that. So what are we going to do? So we're going to educate our doctors on this. We're going to talk about opiate prescribing and limitations of it, all other alternative treatments for pain, screen for substance use disorder. We're going to talk a little bit about that. Treat substance use disorder or make the referral, right? And then drug test patients on opioids. I'll talk very briefly about that. And our PMP, our Prescription Monitoring Report, or the New Jersey Prescription Monitoring Report, which now is law that everybody has to register for that. Quick study, really quick. This is called the SPACE clinical trial, which looked at osteoarthritis and back pain, and they compared adjunctive analgesics to opioid therapy. And actually what they demonstrated that there wasn't a big difference in this cohort of people who were on opioid therapy. So adjunctive analgesics work. So I threw this up here, suggested treatment items for different various types of pain syndromes, like low back pain, self-care. Here's the exercise. The one thing that I'm always amazed, and some of you know I've done lots of research, I've done a lot of clinical trials, including on opioids. It will shock you to know that an opioid is only a 2-log difference to get approved in this country. 2 log, that's it. That's how placebo is, the effect of placebo, right? I'm always amazed at that. I'm like, it takes 2 logs and you can get it approved in this country. And that was the study I did, believe it or not, on a morphine product. 2 logs. That's amazing to me. So having said that, things that we do show some really great evidence, like exercise and treatment and mobility, really, really works. And I'm talking to the choir here. I do know that. SNRIs, tricyclics, some of which I was involved in, some of the studies on duloxetine and stuff. They work, right? Osteoarthritis, again, weight loss, anti-inflammatory drugs, injections, acupuncture, right? All these things work. And I'll give you a quick anecdotal thing. And migraines, so I have that all up there. Neuropathic pain, which is actually my specialty. And I was involved in a lot of these trials like gabapentin I was involved in, and pregabalin and stuff. But a few weeks ago, I had to go to a gala, which, it's just getting super dressed up and rubber chicken dinner. You get it, right? And I woke up that day and I could not walk. And I called Dr. King. And I'm like, do something. And he did electroacupuncture. And happily, thank you, Dr. King, I was at the gala. So thanks for that. Appreciate it. It worked. So, all right, so a couple things. New Jersey Prescription Monitoring Report. It is not perfect. I know. I'm a consultant to them. I get it. It goes down all the time. Sometimes it's not as accurate as it needs to be. Sometimes the patients are downright wrong, right? I get all of that. Sometimes the pharmacies don't put them in time or they put them in wrong. I'm not the Prescription Monitoring Report. But I do know all that exists, so we are working on it. The bigger issues with the PMP is, especially the NJPMP, is they don't or they irregularly link up. It needs to be a national database, right? Especially where we are, right? So we could pretty much see Pennsylvania, we can pretty much see Delaware, we can pretty much see New York, but that's variable at best, right? Because of our location, it's particularly difficult. So I am working with the government on that, the state government on that. It comes up literally like every meeting. But I will tell you, it is markedly helpful. It is now New Jersey state law that you have to register for it and you have to look at it annually. Now, I'm going to tell you the other thing is, make sure everybody that if you have delegates, which we need, right? If you have your MAs and stuff and they are logging in under you as a delegate, please, if that person leaves, remove their delegate status, right? This has come back to the board a couple times, right? So just remember that. We don't think of those things. You made them a delegate, they leave, and they might be accessing things, and that comes on you. Remember, whatever delegates do, it always ultimately comes on you. All right, so just remember that. Okay, we look at it like every 3 months. I want to double check everything, and I would always double check your profile in the NJPMP just to make sure it's accurate, right? Because of some of the problems that we have with it. All the states have it. I know Missouri looks a little bit weird there, but it's because they're regional. That's why it's just they do their own thing. But it's everywhere. They just need to link up. And the other thing about where we are in New Jersey, Pennsylvania, New Jersey, New York, we have a lot of snowbirds, right? That they go to Florida all the time. That for me in pain management is like a disaster, right? So right, I know I'm getting a lot. Yep, I feel your pain. I'm right there with you, right? So we try to link them up with providers and the whole bit, right? So the CDC, who was really, really quiet on this for a really long time, woke up one day and they're like, oh, I think we have an opioid crisis, so we should probably put some mandates out, I guess, right? So they started putting some mandates out, and they were pretty simple, right? They're like, non-opioid therapy is not preferred, initially, and go start low, go slow, and do periodic checking, et cetera, right? So I'm sorry. So one of the best screening tools, this is my favorite, is the SOAP-R revised SOAP note. So this is a screening tool for your patients. It's super easy to do. It takes about 3 minutes. You give it to your patients, they fill it out, and then you do the scores, right? And what I like about the SOAP-R is it kind of gives you sort of a risk, a positive risk for opiate use versus a negative risk, right? And then if you actually even go into a little bit further, they even give you recommendations, right? So one of the most common thing people says to me is, hey, Dr. Jermyn, if I have a positive risk on my revised SOAP-R screening tool, does that mean I don't provide opioids? Absolutely not. That does not mean that. It means you're going to watch them closer, right? You may do urine drug screens a lot more frequently than the New Jersey state mandate of annually. Right? You should do it probably a lot more frequently. These are the people I would probably see on a monthly basis and see how things are going, right? So if we ever get in an auditing situation, and some of you guys know I've audited for the medical board and for the state of New Jersey, I always want to see not what you're doing as much as making sure that you are doing all the stuff for screening, right? Screening, and if you see an aberrancy in something that's going on a urine drug screen, you've done something about it. It doesn't mean you kick the patient to the curb. It means you do something about it, and I'll talk a little bit about that in a minute. Okay, urine drug screens, just a nuance with this. Remember that urine is preferred over serum, right? And the reason for that is this, what you're seeing here. We can capture the metabolism of the drug so much better. Let me give you an example, right? So if you look at the urine drug screen up on top for oxycodone, right, you'll see that the metabolites are nicely below underneath it, right? You got oxymorphone, right? What you don't want to see is this huge dose of oxycodone and no metabolites. That means someone went into the bathroom, took oxycodone, and put it in the urine with no metabolites, right? I will let you know there is synthetic urine that is now out there, and you're going to get a urine drug screen that's going to look very, very similar to oxycodone, like that's it, and there's no metabolites. Synthetic urine doesn't have metabolites, right? So that's out there. I see this actually quite frequently. The other thing I want to show you up here is alcohol. If you get low doses of alcohol up here, like 0.185 like we have up on here, they're probably because they're diabetic, right? And it's not because they're actually drinking, all right? So actually what we do is if we suspect there's alcohol, we'll get a breathalyzer test, but low doses of alcohol on a urine drug screen is usually diabetes, okay? So that's to be expected. So anyhow, enough about that. I put this together for you, and it's actually adopted by the state of New Jersey. This is an algorithm that you could take your slide later, print it out, and it really tells you what you should do with your initial prescription, your second prescription, third, all of it to stay compliant with New Jersey and federal state law. Easy peasy, it's right there. Okay, so I just put it out there for you, and you have it. Okay, so we have an opiate crisis. What are we going to do about it, right? So this is what we're going to do about it. So we're going to kind of now go from pain and talk a little bit about addiction. So you all need to treat substance use disorder because it is not rocket science, and we'll get into that in a bit. My job as an educator, train doctors. So I've been training both you guys, physicians that have been out there, but also train trainees, and train medical students. Since COVID started and we became a Center for Excellence for Addiction, I have given about 5,000 Data 2000 waiver trainers. So we are in the state of New Jersey. So we are getting out there and trying to get people to get data waived. We'll talk about that in a minute. Educate your community that you are in. So that's a really big one. The most trusted people in communities are their doctors, by far. And whenever I give these talks, right, people are like, I don't have these patients in my practice. Yeah, you do. You do. You're not screening for them, and they don't have access to you. So I'm going to just challenge you to hear those words. That's how much this is right now. And here's the other thing. Do you know what my average age of my substance use practice is? What do you think? It's not 20. It's not 40. It's 55. Elderly people went to Woodstock, right? 69. And I find for some of our elderly patients, they've been getting opioids for many years, and then we find out that they actually have a substance use issue. They're my most difficult cohort because they just don't want to hear it. They don't believe it. They just don't want to get there. Yet their children have a substance use problem, and their parents had substance use problems. And they'll say, my father was an alcoholic, and I'm like, this is genetic. We need to take the stigma away from substance use disorder and treat it as a chronic disease, period. And you don't treat it different than diabetes, and you don't treat it different than anything else. We got to stop the stigma, because this is a genetic disorder. And what else do we do? Prescribe and give naloxone. Now, it is state law right now that you should be prescribing naloxone if you have someone on 90 milliequivalents of morphine or greater, right? And you're going to be like, all right, oxycodone is 10 milligrams at times 1.5 is the morphine. Just give it. Don't even, like you're going to sit there and like, I've got 80 milligrams of, just give it. I'm going to prove to you why it's so critically important. Okay, medication-assisted treatment, or you're going to hear maybe a more updated medications that treat opiate use disorder, is evidence-based, right? So what that means is we know that we can treat people with medications that will treat their substance use disorder and are going to prove to you treat their pain at the same time, okay? So currently, as an outpatient in primary care especially, we have two medications that we can use. One is buprenorphine or Suboxone, as you guys probably have heard before, subs, or naltrexone, an extended release formulation, which is an injection called Vivitrol, but it's also available in oral formulation, which, by the way, has demonstrated great analgesic benefits in neuropathic pain. All right? Medications that you could prescribe for substance use disorder, also known as methadone. It needs to be done in a federally qualified program or a methadone clinic. So physicians aren't really able to do that unless you work in a federally qualified program. But before I get the question, yes, you can write it for pain. Don't ask me why the restriction exists. I didn't make the law. Okay, methadone's been around for a really long time, since the 1960s, proven efficacy. And why does it work for substance use disorder? Because it's a very, very long half-life drug. So if a person takes it once a day, that drug can stay in the system and it takes down cravings, et cetera. So it's also a very good analgesic. What are the problems with it? It's a full mu agonist. And it stays in your system for a really long time. And some people can get overlapping half-lives depending on how they metabolize methadone. And as we all age, I hate to say it, I'm one of them, as we age, our ability to metabolize things over time changes, right? And that's why we always have to look and reevaluate these things, right? So that's methadone. Buprenorphine really has been around since 2000, known as the DATA 2000, is a special program that one would take to be able to write buprenorphine or Suboxone. Now, what is buprenorphine? It's a partial agonist, right? What does that mean? It means it sits on the mu receptor, but it doesn't stimulate it fully. So you don't have the euphoric effects that you get with full agonists, right, like oxycodone or even methadone, right? And you don't get the other negative effects as much, like minimal respiratory depression, which makes it very, very safe, especially in our elderly population, which is why I love it for our elderly population, and a little bit less constipation, all of these kind of things. So the benefit of a partial agonist is huge, right? And let me just say, I'm going to say it again, it's a great analgesic. It's a great analgesic. So, and great studies, which I'll give you just, we have a couple products that are out there just for pain that are buprenorphine products. The problem with them is they're just not big enough as far as doses. Now, here's the problem. If you're like, well, I'm going to give Suboxone to treat pain and only pain, right now it's only indicated for substance use disorder. I'm working on that, stupid as it is. I make people sign waivers for me here, like I want to use this for my pain syndrome because I don't want a full agonist when patients come in, and we make them sign waivers so that they know, because, and we'll get a little bit more into that. Now, Trexone is an antagonist. So what that means is, and you know it as Narcan also, right? So if you have a mu, something's on your mu receptor, whether it be a full or partial agonist, you give them naltrexone, bam, it will completely displace that, and then you'll go into withdrawal, right? So that's why with naltrexone, if you use it for opiate use disorder, you have to be off opioids for at least 2 weeks before we can give that as because you'll go into full limit withdrawal. Same thing with partial agonists, and this is an interesting thing about partial agonists, meaning buprenorphine, is not only is it a partial agonist, but it has a greater affinity for the mu receptor. So what that means is if you've got, say, fentanyl or oxycodone on board and you give them buprenorphine, the buprenorphine will completely dissociate that oxycodone, and because it's a partial agonist, you're going from this dose to this dose, you're going to go into withdrawal, right? So you want the patient in moderate withdrawal before you induce them on buprenorphine products. Did you guys follow me on that? Does that make sense? I actually just published an article in the JAO on how to do this in the outpatient. So take a look at that. It goes through a lot of these details more than what we're going to talk about here. Okay, so medication-assisted treatment works really good when you kind of link it with behavioral health and you link it to take care of underlying depression and anxiety, and of course, monitoring the patient, right? We want to see them a little bit more frequently. The DATA 2000 is a special training program. Now get this, you graduate from medical school and you might get 2 hours of opioid training in medical school, but not our school. And you go out and you could write hundreds of milligrams of full agonists of morphine and oxycodone, and no one's going to say a thing. But if you want to write a partial agonist with no respiratory depression components to it and little to no euphoria, you've got to take an 8-hour training program. How insane is that? So we're working on this both on a state and federal guideline to get that changed. And we got a little benefit to it. And that benefit says, hey, register for the Data 2000 training program, and you don't need to do the full training program for your first 30 patients. Okay, what does that mean? Makes no sense. So, but we're working on that, okay? If you decide to do addiction treatment, opiate, I'll call it, substance use treatment in your office, there are requirements. The first year it's 30, then you would have to take the full Data 2000 8-hour training program, and then you can go higher and higher doses. We are working furiously to change that because it adds to the stigma. Like doctors are like, this is the easiest thing in the world I could do all day long, and you'll see people that do this, pain is so much harder than substance use disorder. I promise you that. Yet somehow all these restrictions exist. Okay, so you can log on, get your Data 2000, you don't have to take the huge training program, you could start doing this almost immediately. Okay, so what are some of the barriers for our patients to get into treatment, right? Barrier number one, we don't have enough people doing this. So there's great studies out there that says because of the extent of the opiate crisis, if primary care doctors don't start doing this, we will never, ever get ahead of this disease. Great studies. If we don't start doing this in our doctors, our trusted doctor's office, this is going to get worse and worse and worse. You do not need to go to a specialty office to get OxyContin. You do not need to go to a specialty office to get buprenorphine, quite frankly. Okay, detox programs. Like, okay, I'm going to send you to an inpatient detox program. About 80% of them do not do medication-assisted treatment, or they do it for a very short period of time, right? And then you have the highest risk for overdose after you leave an inpatient detox program. Has anybody here, by a show of hands, heard, had been involved with a patient, or even family have known, have gone into an inpatient detox program, didn't even finish it, left, and overdosed? Show of hands. Yep, that's the data. 300 greater risk of death if you're not linked into an MAT program and then into the community. Why? You know why. You go in, 7 days, they detox you, they wean you off everything, they're like, you're cured. You have no dopamine because the last many years you've depleted it, and the only way to get it was to use, right? You think you got your dopamine back in a week? Of course not. The data shows, Samson data is very, very clear. A year, and when people come into our program and we initiate this, I say, and they're like, my family wants me off this, right? It doesn't, they're saying it's a drug for a drug, which we're going to get to in a minute. And I say, no. First of all, I'm not treating your family, you're treating you. 2, have you done this before? Yeah. Did it work? No. Why? Because your brain needs to recover. That dopamine needs to come back again. Over time, it's a year at best. A year. That's what the data shows. And I can show you graphs that will show that every month that you have, first month, you're relapsing, done. You're done, right? Second month, and it's like this, up to a year. By that 12 months, maybe, we can start having that conversation. Maybe. And that's what I tell them. And I keep the door open. How many people here start people on insulin and say to them, okay, you're going to stop eating cake. You're going to stop eating cake tomorrow, right? Because I'm only giving you insulin for a week. It's a chronic disease. We don't treat people like that. It's malpractice. But we do that for substance use disorder, don't we? Because we, as doctors, have it in our mind that this is not a chronic disease, that you do it to yourself. Absolutely wrong. It's a chronic disease, genetically linked to you. We know the data. It's clear. It's a chronic disease, and we need to start treating it like a chronic disease. All right. All right. What do we do at Rowan? We train doctors, we train student doctors, and we educate them, because that's what we need to do. Okay. This is the data waiver stuff. Log on. Just start looking at it. It's right there for you. All right, myths. Buprenorphine is a replacement drug, right? It's one drug for another. Garbage. It's a partial agonist. It's not a full agonist. You don't get euphoric. It takes away the cravings right away. And, all right, let me give you a scenario. We're working on this with our EDs right now. You have an overdose in the community, right? And you go into the emergency room right now, and you see someone, and you're in withdrawal because you just got Narcan, right? And you're like, Doc, I got to get out of here. I got to get out of here. I got to get out of here. Why? Because people with substance use disorder are terrified of withdrawal. It's inhumane. It's probably the most horrific thing a person could go through. And then what do? Oh, look at him. Did it to himself. Don't you stay away from drugs. See what happens to you? Give them Suboxone. Within 5 minutes, all of that goes away. They feel better. Now you got a partial agonist on there, right? And if they leave your ED and they use on top of it, they ain't gonna die. Do you know in South Jersey right now, we are working very, very closely with all our EDs to try to get them to just do that. Just to do that. And I understand it. People feel this is, I'm worried about the whole thing. But if you were a diabetic and you went into the emergency room, right? And you're in diabetic ketoacidosis. I'm not smart enough to be internal medicine, but I know that's a thing, right? And I know it's bad, right? And someone came in there and said, all right, here's a little bit of insulin, don't eat cake, get out. Right? That would be kind of malpractice. So guys, I'm always, bringing you what's coming, right? So this is going to be mandated that we have to start doing this. And then we need to link patients from the emergency rooms into their trusted family doctors to take this over. We have to do that, okay? Detox, withdrawal management is an effective form of opioid use disorder. I just explained to you why it is not, right? Prescribing buprenorphine for opioids is more dangerous than other forms of chronic pain management. It's better, I just explained that to you. It's a partial agonist. And then finally, buprenorphine as a primary care office setting is too time consuming. No, it's not. It's, again, the easiest thing you'll do all day long. Not only that, but it's the best thing you'll do all day, because you're going to say, wow, today, I think I might have saved someone's life. And you don't get to say that too many times. At least I don't. Okay, stigma. All right, we got to get rid of stigma because it's a lot of it. It's in every single one of us, right? We all have stigma stuff, and we all have to go deep with that, right? And we put it part of the community, didn't we? It's like, wow, you're an addict. No, you're a patient who suffers from a chronic substance use disorder, right? So your drug test is dirty today. So if someone's a diabetic and they've got blood sugar in their urine, does that make it dirty? It's a positive or negative test, correct? That's how we have to describe it. Patients come into me and are like, Doc, I'm an addict. I say, no, you're not. You're a person with a chronic disease, and it's called substance use disorder. We don't use the word addict in this office. They cry. They're like, oh my God, someone's starting to hear me. Oh, Doc, I did some bad stuff when I was using. You didn't do bad stuff. The disease made you do bad stuff. That's why you're here today and you're trying to get help. Two separate approaches. One works, the other doesn't, right? How many people here have a dog? Right? Yeah, I do. Trust me, my dog is more important in my house than I am. I have to climb to the bottom to get to where my dog is, right? True story. His name is Cole. When you train your dog, do you beat him into submission? Yeah, you do. Some people do. Or do you reward them with good behaviors? One works, the other doesn't. One changes behaviors, the other doesn't. When someone comes in to me and say, doc, I know my urine drug screen is going to show I used, and I say to them, okay, when you came to me, you used every day. I said, how many times did you use last week? 3. I'm proud of you. Thank you. Doc, I haven't used opioids now for a month, but I can't stop drinking. I'm proud of you that you stopped using opioids. Now let's talk a little bit about the alcohol. Meet them where they are, right? The worst thing we could do is say, okay, I'm going to start doing this, and you have a urine drug screen, you go in there, it's negative, it's positive or dirty, and you say, all right, I'm done, get out. They're going to die. They will absolutely die. I promise you that's what's going to happen because you're trusted to them. Okay. Again, I kind of just said all of this stuff, that stigma hurts people. Cultural stigma hurts people. And then if we give disease a culture, it's stigma, right? Didn't we do it with HIV? Only bad people got HIV, right? It's a chronic disease. We did this many years ago, right? Now, we cannot do this for substance use disorder. Too many people are dying. Okay. Okay. What can everybody do? Okay. So, doc, I'm afraid my son is using. I'm going to write you a prescription for naloxone. Take it home. Right? That's what you can do. So, in the state of New Jersey right now, naloxone is $35. You can get over the counter. But with inflation right now, the average person, you're going to spend $35? Other states that have been very successful have subsidized naloxone to like $5 or $10, but not here, right? So it's a big barrier, right? So I'm working on them to try to see what we can do about that. Naloxone saves lives, period, right? No, doc, if I give naloxone, doesn't it say it's okay for my kid to use? Absolutely not. You guys remember the AIDS crisis? Didn't people literally protest condoms? Didn't we say, use condoms, right? Yeah, but that's saying it's okay to have sex. No, it's not. People are having sex. It's saying if you're going to, at least protect yourself. It's the same thing. And don't even get me started on safe injection sites, all right? Because safe injection sites, every time someone enters there is a chance to get into treatment. That's what they're there for. And to save their lives. And we have all of this stuff. Well, you're saying it's okay to use. They're going to use. We're going to make sure they don't die. And while they're there, what are we going to say? Here's a way to get into treatment. When you're ready, we're here for you. What do you need? Do you need food? Okay, this is what naloxone is. The nasal spray is easy, right? That's what we've done. So we have actually a SAMHSA grant right now where I put medical students on a Hope One van I'm going to show you in a few minutes. And after an overdose here in Atlantic City, we go out, we give naloxone to the community, and we train and educate them on its use. Pretty cool. Okay, and these are the take-home kits, and there's tons of evidence that they save lives. Okay, so I love the Scotland National Naloxone Program, and what they did was for prisoners leaving in Scotland, when they left prison, they gave them naloxone. And what they demonstrated that there was a 36% reduction in opiate overdose deaths rates in that cohort, 4 weeks. Huge. Think about that, almost 40% reduction in death rates just by giving them naloxone. Now, you don't use naloxone on yourselves, by the way, right? Or you all know that, right? So you have to train other people around you to use it. So, okay, some resources for you. If you want to see what your overdose death rate are in your community, go to njcares.gov. You'll also take a look at what the prescriptions look like in that county also. NJ Reach, this is a 24-hour hotline, so if you're like, I'm not ready for substance use, but I'm going to give this to my patients so that they can get access to care anytime they want, it's right there, okay? And then I'm going to kind of end with this. This is Hope One, and one of the other programs that we had is, and I think you're kind of seeing this, like what can we do? How do we reach our patients? And especially our most vulnerable patients, right? How do we reach them? Well, during COVID, it was great. We had this amazing vaccination program. on campus, and we were the largest in the state for a while, and we got a ton of people in. But then we noticed our most vulnerable patients, our homeless, our patients of color, our migrant community weren't coming. So we decided to say, well, we're going to go on a van, and we're going to go out and start vaccinating people in their own community. And this is a picture from earlier today. So earlier today, me and my amazing medical students and trainees were out. This is the Atlantic City bus terminal, and we were on the Hope One, and we vaccinated 50 homeless people this morning. Some of which, or the last time they were vaccinated, were with us. So we're out in the community. What we did, this very same van, we have a pilot project right now. We're doing telehealth for substance use disorder, for the homeless. So we were out 2 days last week where patients are coming up to the van. We have a doctor on the other side and prescribing Suboxone to those patients and getting into mental health care and need. So, which I think is very cutting edge. And I'm working with my students on that. And we're kind of doing things because part of Rowan SOM's mission is to treat the underserved. And this is it. Right, we're in the community, having the conversations with the patients directly. And of the 50 patients today that we saw for their vaccination, about 10 of them we got into treatment and recovery services. So that was our morning work here at AROC. So I want to thank you all. That's my talk for you. Now, I do want to talk about marijuana because someone's going to ask me. So how many people want to hear about marijuana? Yeah, I know. All right, okay. So. All right, so it's now legalized in the state of New Jersey, and there's so many nuances with that. And so you guys know, I work with the DOJ, the Department of Justice, for the governor's office in the state of New Jersey, right? So, I mean, I'm telling you, this was coming. This was the governor's pet project, as we know. So this was going to happen. I'm like, see how nervous I am because people link me to this. And so there's a couple nuances with marijuana. But before I tell you that, I spoke this past week, literally yesterday, to the circuit court judges for the state of New Jersey on opiate use disorder, on pain, and they were all there, and it went really, really well, as you would imagine. I'm like, stop imprisoning people for a chronic mental disorder when us doctors need to take this back, right? Especially for violations of ridiculous things like they didn't show up at court, where they were using, they were kind of not able to show up for court. They were going through a crisis. And so trying to work with them, and I think we made really good inways. And at the end of it, I was like, anybody have any questions? And the judges said, because it was all online and there was all these things like, well, Dr. Jermyn, we have this overwhelming question from all the circuit judges, right? And before that, it was the family court judges on, what do you think about marijuana legalization? And I was like, why are you asking me? You made the laws. So they're like, well, do you think it's a good thing or a bad thing? I'm like, I don't answer questions like if it's a good thing or a bad thing. I answer questions with data. Right? Which is my cop-out on this. And I'm like, we just don't have enough data to really determine where this is going to land, okay? You can ask my personal opinion, that's completely different, but what about data? All right, so there's a couple nuances with this that you all need to know as physicians. One, it is still federally scheduled number 1, right? OxyContin's 2, to give you an example, right? So that means it's technically still illicit federally. Okay? So now we have a product that's federally Schedule 1, but now you can get it pretty much anywhere. So all right, so what do we do for our pain patients, right? So that's easy, right? So I'll give you some examples of what we can do. So if a patient's coming in, and this was literally every day this week, and we're getting urine drug screens, and now marijuana is showing up, it is still Schedule 1. So if you're writing for that and someone's for your pain practice and they're on opioids and or benzodiazepines or both, hopefully you're really careful with that. What we do is we say, listen, I get it's legal, right? And I'm going to give you a warning letter, and you're going to put this in your chart. And that warning letter is going to say, hey, I get this is legal in the state of New Jersey, but this could affect your care, and we would ask that you would at least be referred to get like a medical marijuana card. And that way, if they get a medical marijuana card and that's on your chart and you have the warning letter, with your first violation, you're golden. You're going to be fine. No one's going to come after you for that. Our substance use population, right? If I considered marijuana for my substance use population as a violation, I would never sleep. Period. I would never sleep. So we don't consider it a violation. In fact, there's even some data out there that shows that marijuana, and don't you quote me on this, because it's anecdotal only, but there's some data out there that says it does decrease relapse rates in people in early recovery who are marijuana users, but don't you quote me on that, all right? We need to do good data. 3, why don't we do good data? Because it's a Schedule I. That's like going to the FDA and say, I want to study cocaine, right? And they're going to be like, yeah, right. So that's why we don't have studies on this. They need to descheduleize this drug and make it like alcohol. And if they did that, we could do studies galore. So now, you're like, all right, what about me as a doctor, right? And I know you want to know the answer, but no one's going to admit it, all right? So you're like, I'm a doctor, and I don't know, it's legal, right? What about me? And I will tell you, the dean put out, who's sitting here right now, this wasn't legalized within 24 hours. We didn't get an email saying, just so you know, marijuana is legal, but it's not legal in our community, right? Just so you know. Here's your problem, all right? Some people have gotten a little caught up in other states that have done this before, right? And the question is, can you as a physician be considered a federal employee? Let me explain that. Since it's a federal illicit substance, that means if you're a federal employee, military, I can't even, maybe the president, I don't know, then it's a Schedule I. That means that's illicit, so you can get in all kinds of trouble. The nuance with physicians are this. If you accept Medicare or Medicaid as federal insurance, you are considered a federal employee. I didn't make the law. Okay? Put your sharp objects down. I didn't make the law. So the nuance is, if you're considered a federal employee because you accept Medicare or Medicaid, then technically you have to abide by federal guidelines when it comes to scheduled stuff. Okay? And yes, other states, this has gone to their medical boards. So that's all I got with that. I can't go anywhere without the marijuana question, but you're armed with knowledge now, right? So the question would become, now it's all brand new, would the medical board ever go in that direction for physicians? I just don't know. I will tell you, impaired physicians, it's tough. See how nervous I am? Like you don't even want to go there. And so I think the medical board should need to put out a proposition statement about what they think, in regards to this, which I will guess if I was the medical board, I'd be really scared to do that. But yeah, so that's kind of the unknowns that we have now. And lots of other states don't have good guidance for us that have gone before us. So that's my marijuana answer. So, and I don't know where we are with time, but I would be very happy to answer any questions anyway, or try to answer any questions.
So at the risk of asking a practical question, what do I as a prescriber need to know about drug interactions when it comes to marijuana and pharmacology?
Yep, amazingly good question. We don't have data to even begin to tell you about drug-drug interactions with marijuana. What I will tell you, and having done this and both with substance use as well as pain and people that have marijuana cards, my overall feelings, it just increases the sedative quality of when you add them all together. So I would look at marijuana as increasing sedation so look at your other products, right? I would be very concerned with benzodiazepines, right? Mixing that, with marijuana products. So that would be my biggest concern. But if you want data, remember I told you I'm a data guy, so I just don't have data to look at drug-drug interactions with it. It just doesn't exist.
All my patients who are on chronic opioids have Narcan. However,
Perfect.
some of it's 2 years old, 3 years old. When does it have to be renewed? How long does it last?
So annually, you want to renew that
Right,
annually? Yeah, the shelf life is pretty good with Narcan. I will let you know, but our process is annually. So, and I'll be honest with you, just so everybody knows, because I'm going to get this as a question, the law says you have to prescribe it. The law doesn't say anything about making sure that they picked it up at the pharmacy or what they did with it. Okay, so just so we're clear on that, because again, you need to sleep too. Okay.
Could you just clarify? You said that a patient who has a substance abuse disorder and has marijuana in their urine, you're okay with that. But a chronic pain person, you're not okay with that. What's the difference?
Just because of the guidelines through American Pain Society. By the way, I am okay with it if they have a marijuana card.
Yeah, but like that's what I'm trying to say.
I-
I don't understand. I think we're splitting hairs. No.
If we're splitting hairs. Yeah, I agree with that. I feel like that in the substance use literature, it supports, to not consider it a quote, positive urine, right? Because it's so. For example, our pathway for substance use disorder, when you bring someone in and we initiate buprenorphine, we see them weekly, right? And if their urine remains negative without an opioid, but positive with marijuana, then we go to every 2 weeks to see them, and then monthly. It doesn't mean that we don't counsel them to get off the substance, right? We do that all the time, but it's just the marijuana, it would be it's really impossible, and you're gonna see this as now marijuana is legalized, you're gonna really see this a lot. But yes, I hate to tell you, pain is different than substance use in this way. My job is to protect you.
Just a quick question. If you have a patient that comes in with the concern of the child having use disorder and you want to prescribe the Narcan, do you prescribe it to your patient? So you write out the prescription to your patient?
Absolutely great question. I have a child I'm worried about. Can I get Narcan? Write the Narcan. I have a grandmother. I have a friend. My neighbor. Write it. It's so expensive, right? The more
Right,
Narcan
but
we
my question is you write it in your patient's name. To
Yeah,
your patient.
absolutely fine. Yep. Actually, the state protects you on that. Can I just tell you, there's a state law that will protect doctors for writing Narcan to anyone they want to. I actually, because we do outpatient, I'll give you a really kind of great example. Since we're out in the community giving Narcan out to anyone who wants it, I underwrite it under my DEA. It's not even a DEA. It's not a controlled substance, just so you know. You don't even have to worry about it. But I underwrite it through the state. So it just comes under my license, right? It's not even a big deal. Remember, Narcan is not a controlled substance. Yep.
In other words, as goodwill, I can write the Narcan, and I don't need to maintain a chart on that person.
You don't need to, I'm sorry? I would document the patient requested Narcan, no questions asked.
Say they're not your patient, but you write it. Can you still write it that way? Is the law, would they have to be your patient and you have to maintain a medical record?
So two ways of looking at that, right? I underwrite Narcan for distribution, and I do that through a pharmacy. So I use a pharmacy to get the Narcan. I underwrite that with me, and I distribute in the community. Those patients are obviously the people we distribute to are not my patients. In your world, if someone comes to you, anyone who asks for Narcan, unless you want to do what I do, which most people don't, but unless you do what I do. In your world, if someone comes to you and says, listen, I'd like Narcan, all you have to do is say, patient requested Narcan. That's it. That's it. You have laws that will protect you. No one's going to come after you in any way if you give Narcan to anybody you want to. But I would put it in the chart.
Dr. Jermyn, just a question of clarification. A few slides back in the very beginning, you showed substance use and the risk of opioid abuse. For example, alcohol, marijuana.
Right.
Is that correlation or causation? I just want to be clear on that. Because it's a question that comes up.
Can't
every
answer
time.
the question.
No.
Can't.
Okay. It's unknown.
It's unknown.
Thank you.
regard to our opioid crisis, right, and all of our deaths, okay, so is it more accidental, more suicidal, or is
you
it,
guys are
or is
so
it more
good.
fentanyl-laced? Do they actually, and does everyone get an autopsy and the toxicology and
No.
stats and all that?
Toxicology, yes, and I'm not. You may have people here that do this, but let me answer your question. You reminded me of something, so thank you. With the legalization of marijuana in the last 2 weeks, I have seen a marked increase of overdose deaths in the state of New Jersey. Why? Because people that are selling marijuana now, and people think it's legal and they're getting it illegally, right? They're mixing it with fentanyl. So the overdose death rates in the last 2 weeks have markedly gone up due to illicit cannabis.
Accidental, so really.
They're accidental.
Suicidal.
Now the second question is, and I'm studying this, so I wish I had an answer for you. Is it death intentional overdose or is it suicide? That's your question, right? So the answer is, I don't know the answer to that, but the literature is trying to find the answer. And let me just tell you something about most people that have used for a really long period of time. After a while, they don't even get euphoric. They are just trying to stay out of withdrawal and just get through their day, right? So by the time, after 2 or 3 or 5 years of using, they're like, Doc, all I do is just, I don't want to go into withdrawal. That's all I'm doing. They're just chasing withdrawal. It's a hard life. So the answer is, I think it's apathy. My personal opinion, I'm a data person. I know I said I'm not going to answer a question, but my personal opinion in doing this is that some people get so apathetic after a while, and they tell me this, they're like, Doc, if I use and I die, I just don't think I care. And that's that dopamine depletion in their brain. They're just like, it's not like I'm going to use to kill myself. It's like if I just don't wake up.
Doesn't mean they're suicidal.
No, it's just apathy.
People say too they're ready to die, doesn't mean that they're suicidal.
Exactly.
So with the fentanyl, so my belief, my do believe because it's chronic diseases, no, but the brain disease, we don't know a lot about it. So really, because of all this fentanyl and everything being laced and everything, that's really where a lot of it comes down to.
So that is why our death rates went up dramatically. Like that one slide I showed you. When fentanyl came on the market, people were not dying at this rate. Fentanyl did it. It's 100 times more potent than morphine, and heroin is morphine. Think about that. And by the way, it's scary. I mean, it's cooked in a lab. You easily can make this, and they're making it stronger and stronger. It's amazing. And it's the only product in the world where you could go to someone and say, hey, this is so good, people die on it and people want it. Like it's the only product in the world when you think about it. It's that good.
I just have a quick question. Like in New Jersey, there's, in pain management, there's in hospice, there's some special rules for that.
Absolutely.
And pretty much you can write what you need to write. But in terms of what were we just talking about? The antidote,
Narcan.
the Narcan, thank you. The Narcan, do you have an obligation to write Narcan in a hospice setting?
No.
You know, given that there might be other people around and you're
Yeah.
writing fentanyl and stuff
And
like
you've already answered, hospice is one of the
Okay.
protected,
Gotcha.
very clearly protected by law. No. No, in fact, we don't want people doing that. Do we have any other questions? Yes. No. Please. Do you want that nightmare? So no, that's not on the horizon. We can't get our act together. I shouldn't say this. We struggle with prescribed opioids right now, let alone. And then let's be honest, the majority of people aren't going to go to a dispensary. They're probably, it's just, so. Yeah, I'm there with you. It would be great to be able to look at that and say, okay, let's have this discussion. But I just don't see that anytime in the near future. Great. Thank you, everybody. This was great.